So who in the audience knows someone who's been affected by cancer? By an autoimmune disease like rheumatoid arthritis? By a neurological disease like Alzheimer's? Yeah, I would expect everyone's hands to be raised because cancer, autoimmune, and neurological diseases affect many people and are complex diseases for which we don't have a cure yet. So my mom, Diane, battled breast cancer when I was in college. Before chemotherapy, she had long, curly, brown hair and weighed about 60 kilograms. After chemotherapy, she was completely bald and weighed about 40 kilograms. As a young scientist in bioengineering, this image of my mom, bald and at a life-threatening weight, was quite some motivation to do better. Fortunately, my mom survived chemotherapy and cancer. However, not everyone survives. What we need, what my mom would have benefited from, and what does not exist today, are personalized treatments, tailored just for our unique genetics, which is the blueprint that describes how our body works, and environmental exposures. For example, the food we eat, the water we drink, and even the air that we breathe, that all have an impact on our health. So today, we are going to put on our scientist cap to develop a new treatment that I want to exist for my mom. If you have never developed a new treatment before, please do not worry, because making a new treatment is a lot like making wine. If we were making wine, our goal would be to make a wine that tastes better than existing wine. For developing a new treatment, our goal is to make a treatment that treats the disease better than existing treatments. We'll have to overcome a series of increasingly difficult challenges, after which a panel of expert connoisseurs will determine if our treatment should be made available to patients. So is everyone in the audience ready to make a new treatment today? Yes. All right. Let's get started. The first challenge is called drug discovery. Imagine we're researching how to make our first glass of wine. We read the literature, we talk with experts, we even do some wine tasting ourselves. We hypothesize that the target grapes to make the best tasting glass of wine is Cabernet Sauvignon. If I just committed blasphemy to any connoisseurs in the audience, I deeply apologize, but please bear with me. For our treatment, we hypothesize the target DNA, RNA, or proteins in the body that cause the disease. As with grapes, this is also the point where the scientific community can get into heated debates. Now imagine we did our research and we're preparing to make our first glass of wine. We optimize the fermentation process, including the combination of water, yeast, and acid that will be added to the grapes to make wine. For our treatment, we optimize a combination of chemical ingredients that form the drug treatment that will hit the target to treat the disease. The second challenge is called preclinical development. Imagine we just made our first glass of wine, but it wasn't easy. Are you going to take the first sip? No way. Back in the day, this would be called the buddy test. Hey, buddy, how would you like to try some wine? Of course, we wouldn't do that. So that's why we first test our new treatment in a safe and controlled clinical setting, laboratory setting, before going to human testing. Which leads us to the third challenge, which is called clinical development. So imagine we just made our first bottle of wine, and it passed the buddy test. Now it is time to test how good our wine is on actual wine drinkers. So we organize a party, and we prepare two options for wine, our wine and off-the-shelf wine, and no labels. The guests of this party, at random, will decide which wine option they will drink. Our goal is to determine if our guests prefer our wine over the off-the-shelf wine. And importantly, guests that drink our wine are not outside trying to dispose of it in the bushes. For our treatment, we run a randomized controlled trial where we compare our treatment to placebo or standard of care treatment in hundreds to thousands of randomly assigned patients. Our goal is to determine if our treatment is better than placebo or standard of care. The fourth and final challenge is called regulatory review. Now it is time to bring in the connoisseurs, who will carefully scrutinize our new treatment as they would a new glass of wine, and determine if it should be made available to patients. Now, the only fine print I will tell you is that, like making wine, making a new treatment is not cheap, nor quick. It will cost us about $2 billion, that's right, billion with a B, dollars, and will last for more than a decade. Yeah, a little expensive and a little long, I will admit, but don't worry. Our odds of making a better treatment are great compared to being struck by lightning. So 97% of all drugs will fail. 90% of the time, cost, and failures incurred during clinical trials, challenge number 3, when the drugs are for the first time tested in humans. Well, no wonder we don't have any personalized treatments, right? We'll all be dead by the time we get any at the rate we're currently going. So why is it such a struggle to develop a new treatment? The reason is that there is a lot about human biology that we still don't know. And I want to be careful here because we've made some amazing progress. Before chemotherapy, cancer was a death sentence. Now we even have treatments that are much more targeted and much less toxic than chemotherapy. The problem with human biology is that the more we know, the more we learn what we don't know. And the only way to learn what we don't know is from human data. We are pretty good at measuring our genetics using DNA and RNA sequencing technologies, but we struggle at measuring our environmental exposures. And we struggle even more at measuring the complex interactions of our genetics' environmental exposures on our health. So anyone in the audience collecting urine or stool samples today? Oh, don't be shy. I see at least one person. Ah, you there with the oversized purse. I know a biological specimen bag when I see one. All kidding aside, even during clinical trials, the amount of data that is collected is minimal because it is such a burden to collect it. We need a technology that can take ugly human data and transform it into knowledge that can be leveraged to create personalized treatments. That technology is called a digital twin. You can think of a digital twin as a digital replica of you based on your unique genetics, customized according to your environmental exposures, and built with the help of fancy artificial intelligence. Instead of my mom asking her digital assistant to make her a recipe, she'll be able to ask her digital twin, "Hey, how is my health today?" Your digital twin can safely run thousands of simulations with every possible treatment or combinations of treatments, reason over the results of the simulations, and identify the best treatment option without you ever having to take a single drug. If my mom's digital twin were to say, "Hey, you better speak with your doctor," her doctor can access her digital twin to identify the most optimal treatment with her. Instead of running clinical trials in hundreds to thousands of patients during challenge number 3 that take over a decade and cost billions of dollars, we could run worldwide virtual trials that can be completed in a fraction of the time and cost of running actual clinical trials. And we can even do better. Instead of arguing about which grapes we should target to make the best tasting wine during challenge number 1, we could just ask all the digital twins all across the world, "Hey, what should we target? And what is the optimal treatment to hit that target?" As you can imagine, drug developers and healthcare providers have been trying to build digital twins for decades, with some success. But the potential of the technology has been held back by a couple of factors. First, powerful enough artificial intelligence to work with ugly human data. Like you and I, digital twins also don't like urine and stool samples. However, researchers like myself are hard at work to change this. And second, lack of patient empowerment. There are exceptions, but for the most part, drug developers and healthcare providers build digital twins in silos on relatively small, incomplete, and biased data sets without the involvement of patients who provided the data in the first place. But human health is a global problem, and human health is a problem that involves every one of us. Every one of us should have a digital twin. And with digital twins, every one of us can and should be empowered to participate in the process of making personalized treatments. All the steps that my mom records using her wearable, all the lab results that she gets during her annual physical, and even the recipes that she makes are fuel to make her digital twin more knowledgeable and more accurate. My mom could lease out her digital twin safely and responsibly to scientists all across the world to help develop new treatments. Yeah, so perhaps you guys thought I was kidding at the beginning of this talk about contributing to making a new treatment. Every one of us has unique and valuable data that we can learn from. Digital twins are the vehicle by which we can capture human data safely and securely to learn about human biology. Of course, my mom doesn't have a digital twin. Yet. We can change that. There are close to 8 billion people on this planet. Imagine if we can learn from 8 billion digital twins. I think that we just might learn how to make personalized treatments for complex diseases like cancer, autoimmune disease, and neurological disease a reality. Thank you.